Foad Taghdiri is currently a postdoc fellow at the Tan Center for Research in Neurodegenerative Disease. He previously finished a master's degree in IMS at U of T. And he's currently using a multimodal approach that includes cerebrospinal fluid, sophisticated imaging for better detection of in vivo pathology in former professional athletes who've suffered multiple concussions. So here's Foad Taghdiri.
Thank you. Good morning, everyone. As part of our project, we are looking at cerebrospinal fluid biomarkers in patients with history of multiple concussions. So, as you already know, concussion is a very common brain injury and accounts for approximately 80% of all traumatic brain injuries. And despite the loss of normal brain function that it may cause, conventional neuroimaging techniques such as CT scans and MRI do not show any abnormalities. As we heard several times this morning, chronic traumatic encephalopathy, or CTE, is a slowly progressive neurodegenerative disease and is thought to be caused by multiple concussions or subconcussive events. However, it should be noted that CTE is a post-mortem diagnosis with distinct pattern of abnormal tau accumulation in the brain. But symptoms of these patients are very similar to other neurodegenerative diseases and overlap with other diseases such as Alzheimer's disease, Parkinson's disease, frontotemporal dementia, as well as other neurodegenerative diseases, and also even, as we learned today, even the pathology of this condition overlap with other disorders. So the lack of an in vivo diagnostic tool has made accurate diagnosis and treatment impossible while these patients are alive. So the objective of our study was to measure and compare CSF tau in vivo in 3 groups of patients. First, retired professional contact sport players with history of multiple concussions. Second, non-tauopathy group, which also included healthy controls. And third, patients with Alzheimer's disease. So we recruited former professional athletes who played in contact sports, including football and hockey. And all of these patients had history of multiple concussions. All of our subjects underwent a comprehensive neurological examination, neuropsychiatric assessment, MRI and lumbar puncture, and also CSF samples of patients with Alzheimer's disease, non-tauopathy, neurodegenerative diseases, and healthy controls were also used for comparison. We used ELISA technique from Inatest company, and we measured beta amyloid 42, total tau, and phosphorylated tau, particularly the isoform of 181 in the CSF samples of these subjects. So, as you know, in ELISA, first we make a complex of antigen-antibody complex, and then by adding a substrate, we can read the optic density, which then can be converted to concentration of these proteins. For MRI acquisition, we used a 3 Tesla MRI scanner, and diffusion gradients were applied in 60 spatial directions. For DTI measures, we focused on 4 major measures: fractional anisotropy, mean diffusivity, ADL diffusivity, or AD, and radial diffusivity, or RD. So DTI is based on the diffusion of water molecule in the brain. So these diffusions can be translated into 3 eigenvalues across different axes. So the longest eigenvalue, defined as axial diffusivity, or AD, and the average of the other 2 eigenvalues, which are perpendicular to the longest one, is defined as radial diffusivity, or RD, and the average of all 3 eigenvalues mean diffusivity. And another very useful DTI measure is fractional anisotropy, or FA, which is a scalar value between 0 and 1. 0 means most isotropic, so water molecule is free to move in all directions. And 1 means anisotropic, and it means that water molecule is restricted. So we think that for white matter tracts with better integrity, they should have higher FA values. And of course, lower diffusivity measures. We used FSL software and seed-based probabilistic tractography, and the tractography for 4 major white matter tracts, the right and left uncinate, superior longitudinal fasciculi, cingulum, and finally corpus callosum. In total, we had 22 subjects in the players group, 9 hockey players, 1 snowboarder, and 12 football players. We also had 12 subjects in the non-tauopathy group, which also include 4 healthy controls, and also we had 12 patients with Alzheimer's disease. There was no significant difference between, a statistically significant difference between the ages of our subjects in these 3 groups. And on this slide, you can see the results for the first of the proteins, which is beta-amyloid 42. So as you can see here, most of our players had normal beta-amyloid, and there was no significant difference between the players and non-tauopathy group. However, the level of beta-amyloid concentration was significantly higher than patients with Alzheimer's disease. Similarly, for phosphorylated tau, as I mentioned, this p-tau is specifically the 181 isoform, which is specific to Alzheimer's disease. Similarly, players had normal phospho-tau. Most of them had normal levels, and the mean was slightly higher than subjects in the non-tauopathy group, but p-value was just a trend towards significance, and it was significantly lower than patients with Alzheimer's disease. But interestingly, we observed that the level of total tau in the CSF of the players were significantly higher than patients with non-tauopathy group, in subjects with non-tauopathy group, and also significantly lower than Alzheimer's disease. So when we saw that there's an obvious bimodal distribution in this group, so we had half of our patients are in the normal tau group, and about the other half had high levels of total tau. We were interested to see what's the difference between the subjects in these 2 groups in terms of neuroimaging or cognition. So we had 10 subjects in the normal tau group and 12 subjects in the high tau group. Interestingly, subjects in the high tau group were significantly older than patients with normal tau. Subjects in the normal tau group scored significantly higher in the trail-making test, part B, and also these patients had significantly better integrity in the right superior longitudinal fasciculus, particularly mean diffusivity. And also, again, subjects with the normal tau levels in the CSF had better integrity in both right and left uncinate fasciculi. So in summary, levels of total tau in the CSF of players with history of multiple concussions was significantly lower compared to total tau in the CSF of patients with Alzheimer's disease, and was significantly higher compared to the non-tauopathy group. Also, higher total tau was associated with low scores on trail-making test part B, as well as lower integrity of SLF and uncinate tracts. So before I finish, we would like to thank all the participants who contributed their time and experiences to this project. And thank you so much for listening.
Time for one or two questions.
You're looking at biomarkers for concussion. Dr. Nina Kraus at Northwestern University has been looking at complex ABR. Sorry, there, good. So Dr. Nina Kraus at Northwestern University has been looking at biological markers for concussion, and she's using a technique called complex ABR, which looks, and I guess it stems from the fact that many people with concussion have difficulty filtering noise from speech, or they have, they just have difficulty with speech afterwards from background noise. So she's using a FFR technique for complex sounds in an ABR, auditory brainstem response, and she's using that as a biological marker. The paper just came out, and I'm just wondering if there is any other thought in the audiology field, or that you've known of in the audiology field, that would help with the biological markers.
Nothing that I'm aware of. For my projects, we are looking at different, we are more interested in just the neuroimaging parts of that, such as DTI or PET scan, and also CSF biomarkers, and particularly Alzheimer's biomarkers. We are also looking at some eye tracking stuff, like self-face CADs or other visual. I have another presentation this afternoon about that. But for audiometry, I'm not sure.
Okay.
No. Thank you.
Good morning. Thank you for that presentation. I quite like the design study. I had a question. You mentioned that TRAILS-B was different with the low and high tau proportion for the multiple concussion patients. Can you tell us what other tests you used and whether there was differences or not?
Half of our players were from Bakerest Hospital, so there was some overlap between neuropsychological assessment from our group and their group, and also education was different. So education of the football players was in average 4 years more than hockey players. So we try to only select the cases, the tests which are controlled for both age and education. So we looked at trail making test and STMT, and also I used RAVLT, Ray Auditory Visual Learning Test, and I controlled that one for education. We didn't find any difference for STMT or RAVLT. Okay, thank you. Thank you so much.